and opportunities for pediatricians to integrate clinical medicine and public health. As I mentioned before, Jackie and I co-manage this special interest group, and we are both members of the section on epidemiology, public health evidence, and the Council on Community Pediatrics. Next.
Thank you, Jackie and Amanda, for those opening remarks. I'll turn it over to our Senior Project Manager for the Practical Playbook, and Tia's going to walk us through an overview of the Practical Playbook, including some tools and resources that can be helpful in fostering partnerships.
Okay, thank you. So just a few slides on our Practical Playbook website and a little background. The Practical Playbook is devoted to establishing meaningful partnerships across diverse organizations and individuals. Most importantly, the Practical Playbook itself is a partnership that brings the talents and perspectives of multiple organizations to the table. The organizations include Duke Department of Community and Family Medicine, the DeBoe Foundation, the Centers for Disease Control and Prevention, and Health Resources and Services Administration. The Playbook, or PPB as we call it, is built for a variety of audiences, individuals who haven't worked together in the past or don't have an understanding of the value of working with partners to improve community health, those who are interested in starting to work with partners, and who are already working and want to deepen their relationship. So how can the Practical Playbook help you? Practical Playbook source that offers fundamentals and step-by-step guidance to help you partner and improve population health and the health of people and communities. The Playbook will help you to be a success by connecting experts and stories of success that help you work together, work with get funding, and understand the healthcare system as examples. So, getting the fundamentals. So, a question along that line might be, what is population health? Why the partnership? And what makes partnerships successful? The Institute of Medicine identified 5 principles of success that enable primary care and public health groups to work together. These principles were hallmarks that have survived the test of time of the vast majority of partnerships and programs that started, maybe flourished for a while, and faded as time and early leaders moved on. These survivors had several elements in common, and they included a shared goal of population health, community engagement, aligned leadership, sustainable systems, and collaborative use of data analysis. These goals might not be equally apparent as the work begins, extremely visible and important as the work of partnership progresses. So, collaboration between primary care and public health is a powerful tool for improving community health. Understanding why collaboration works is necessary, but it's not enough. Turning knowledge into action is the key. The Practical Playbook outlines step-by-step guidance to plan, organize, implement, and evaluate your project in easy, again, step-by-step implementable action. To the steps that are outlined for building partnerships, the Practical Playbook offers expert insights about various steps and pitfalls that can occur bringing health and primary care together to improve population health. Given the role of data in identifying health problems, aligning efforts, evaluating progress, and identifying success, some expert insights might focus on the importance of data and metrics, with special sections on even using data in this digital era. Here in this section, experts of their perspectives on the current context of public health and healthcare systems in detail. And last, success stories of partnerships or examples of partnerships. A diverse collection of stories can be used to inspire efforts in your own community, whether you're in the early stages of working together or attempting to measure your impact. We continue to update our stories as each of our partnerships evolve. And
thank you, Tia, for that overview of the Practical Playbook. So our speaker is going to be Dr. Phyllis Agron. Agron currently serves as a professor of pediatrics at the University of California, Irvine. He is double boarded in pediatric gastroenterology and general pediatrics and is on staff at the UCI Medical Center, Children's Hospital in Orange County, and St. Joseph's Hospital in Orange County. Dr. Agron is a fellow of the American Academy of Pediatrics and is on the National AAP Executive Committee Council on Injury and Violence Prevention and the Violence Prevention Subcommittee. Dr. Agron founded the UCI Childhood Injury Prevention Research Group and has a long history of translating research findings into evidence-based guidelines and interventions for preventing injuries. In 2011, she founded the Clinic in the Park, which we'll hear about shortly, where currently serves as Executive Medical Director. Dr. received her Bachelor's of Arts degree from the UCI Berkeley campus, her Master's degree in Biology from Boston University, and her Master's of Public Health degree from Harvard, and her medical degree, residency, and fellowship training at the UCI School of Medicine. Dr. Agron has drawn on her experience to become a leading advocate for policies and programs locally, statewide, and nationally to prevent pediatric injuries and promote better health and outcomes. Dr. Agron, I will now turn it over to you.
Thank you very much. Next slide. Okay, Park is designed to connect, screen, and educate families using public space for health. We evolved as a large health collaborative of pediatricians, community, academic, public and private organizations, and volunteers providing health and wellness services. In 1999, and I'll just give you a little background about the Orange County Great Park where we started, the El Toro Marine Corps Air Base in Central Orange County was closed by the U.S. Department of Navy. A Irvine City Council led the successful 10-year effort to secure city control of the land in order to begin the process of building a major metropolitan park in the first half of the 21st century. This is a series of design competitions and adoption of an award-winning master plan for the Orange County Great Park. In a short time, an iconic giant orange balloon was installed, carrying passengers up 500 feet, an overview of the entire county, installation of a restored historic carousel, kids' play area, a farmer's market, and the introduction of programs and events that routinely attracted 5,000 to 10,000 visitors on a weekend, all this at no cost to the public. A frequent visitor, along with my husband, happened to be on the city council and mayor of the city during this time. We felt that the Great Park, even in its earliest phases, might be an unusual venue for chatting with families about child health. The process of creating the Clinic in the Park began. Next slide. Next, okay. It shows about poverty nationwide on the left and poverty in our county. Tale of two cities with very wealthy communities on the one hand and very low-income communities on the other. In some communities or cities, greater than 30% of children live below the poverty line, 1/3 overweight and obese, 1/3 of our children have untreated dental disease, and we are the second highest county with respect to food insecurity in California, with a UCLA study showing 54% of our families identify themselves as food insecure. And we all know that poor health translates to poor academic performance. AAP has been discussed before, is outstanding in promoting poverty and child health as our major platform. Next slide. Goal again are to connect, screen, and educate. We want to provide access to health services in unusual public venues. We want to become a sustainable community resource, particularly in underserved communities, and maintain the venue where health organizations and others can provide one-stop shop for services. And what created here is a team of collaborators who, one, learn about resources in the community, two, connect to pediatricians, and three, begin to cross-refer between their own organizations. Next slide. Next slide. Okay. That just depicts some of the services that we offer. In the upper left, these kids were prematurely placed in lap shoulder belts, and we measured and instructed them in booster seats. We have our Healthy Smiles program doing oral health exams, fluoride monitoring, connecting to dental homes. We have our Safe Sleep station. We have our Healthy Eating station. We have connectors to services and public benefit programs, and we've added community CPR. Given us, the Orange County Great Park, due to a change in leadership, has deviated from the master plan to the point where it no longer attracts the underserved community. They're charging for services and they've decreased programs. So as part of our collaborative input, evaluation, and discussions, we decided to downsize the Great Park venues and hold special events there and take the clinic mobile to underserved communities. Next slide. This is a key slide in terms of establishing sustainable partnerships. First, we have to document the children's health needs in our community. We have gathered together those organizations and individuals who had an aligned mission of promoting optimal health to children and their families. We needed leadership that was credible with uniform messages, and I put in red there, the American Academy of Pediatrics. We needed a diverse collaborative that included community nonprofits, academic institutions, families, public policymakers, private and public organizations, and volunteers. It's critical that we establish policies and procedures. We create a letter of intent if you wanted to join, which we have many organizations wanting to join. We ask that you fill a letter of interest or intent and demonstrate the public benefit to the services. We vetted each organization. We vetted if they were deemed appropriate and aligned with our mission. We created a memorandum of understanding between our nonprofit fiscal sponsor and the organization. Sustainability is critical. We have to diversify our revenue sources and leverage revenues with other organizations. Data sharing is also critical because by providing the results to our member organizations and the larger community, we're demonstrating the value. We continuously evaluate, remodel, reassess, engage our partners, and determine future directions. I would 50% of our budget is in-kind donations and services. The next slide shows a list of our collaborators. I pointed in red our founding partners, which were about 15. We've grown to over 50 partners, providing services, provide technical assistance, expertise, and participating in our revenue generation. Period. Strength of our partnership is really vested in a spectrum of resources and services contributed by each partner with the aligned mission of addressing the needs of children in our community. The slide shows an example of what we create after each clinic. This is a clinic in a low-income area in Madison Park and the adjacent school, which is in Santa Ana. And at that first pilot clinic, we did a convenience sample survey looking at the needs of the community. So we reported on the left the number that had an annual income below the poverty line, and here are some of their service needs. After we did this initial clinic, we reported out some of the outcomes. Safety education, bicycle helmets, booster seats, early literacy, dental services, and so forth. We try to attach a cost savings, and we know from the literature, for example, Miller's work that $50 invested in a car seat could save a potential $2,700 in cost should the child be injured in a crash. Next slide. I just want visitor comments, and I think the central one characterizes what we're doing. We're friendly, we talk to the visitors, we provide information, we answer their questions, and then the center of this, they are not rushed like a doctor's office. This is really designed to enhance what we can offer in a well-child visit, which could range from 11 to 20 minutes. We address the needs of the child the needs of the parents. We have certain things we have to do in a child visit. So some of these services can be enhanced in the clinic in the park. At the bottom, we always like to have special events. If any of an older generation remember, Bobby Rich was an all-star second baseman for the Angels. So we want him to come out and talk to the kids, get on the field with them, and emphasize healthy eating, team sportsmanship, and physical fitness. And he signed pictures, autographs, and this is a great hit with the kids. Next slide. Research agenda, and that's where we work with our Institute of Clinical and Translational Science at UC and our Department of Pediatrics. And major questions center around, can public space be used for health to enhance access to community resources and education? We know as pediatricians we must collaborate and connect families to community resources. What's the impact of this large community health collaborative? Can health be effective outside the traditional medical home and office visit? And can we create a replicable and sustainable model? Next slide. We were pleased to report that we received a 2016 California Department of Public Health Innovation Award. We were able to present a panel with many, many other innovative programs throughout California. And we're on the panel about creating healthy communities. Next slide. And it's really critical to thank your funders, to thank your participants, to reinforce your collaborators, to provide feedback, provide data, and listen to all of the collaborators regarding the services and how we can continuously improve and expand our services. Thank you.
Thank you, Jen. And just a reminder to all of our participants, chat questions for Dr. Agron in the chat box, and we will address those during the Q&A portion after our next speaker. So our speaker is Dr. Roderick King. King is currently the Chief Executive Officer for the Florida Institute for Innovation and holds faculty appointments at the University of Miami Miller School of Medicine, Department of Prior to this, Dr. King was the New England Regional Director for the Health Resources and Services Administration, a commander in the U.S. Public Health Service, and former Senior Advisor to the Bureau of Primary Health Care at HRSA. King holds adjunct faculty appointments at Harvard Medical School, Department of Global Health and Social Medicine, Massachusetts General Hospital Disparities Solutions Center, and the Department of Health Policy and Management Center for Public Health Leadership at the Harvard School of Public Health. King is board certified in pediatrics and is a fellow in the American Academy of Pediatrics. We'll now turn it over to Dr. King.
Thank you very much. Can you hear me okay, Courtney?
Yes.
Great, thank you. Well, good afternoon, everyone, or good morning. Thank you for the time to share a little about some of the work that we're doing here in South Florida. And I wanted to take just about 7 or 8 minutes to talk about working collaboratively for results and grow our conversation in some work that we're doing through our Build Health Challenge grant for Liberty City. Next slide. What I'll do is just spend a couple of minutes talking about our Liberty City Collaborative for Change, our Build Health Challenge, talk a little bit about what we've learned and garnered and what we wanted to share with everyone around best practices around mobilizing leaders for effective change within communities, and then end with a short blurb and slide on the role and leadership of pediatricians, because I think pediatricians play a very critical role in helping tackle some of the truly challenging issues public health population has used within communities. Next slide. Jump into that just to give you a very brief overview about the Institute. We are, as Courtney mentioned, the Florida Institute for Health Innovation, formerly the Florida Public Health Institute. And our core areas of work primarily center around health and policies, impact, what we call getting leaders to take aligned actions for healthy communities, and research, evaluation, and training. So the work that I'm going to be sharing with you today falls under our center core piece of work, which is around getting leaders to take aligned action for collective impact. Next slide. So to set the context is to talk about the Liberty City Collaborative Change, our Build Health Challenge grant, and the work we've been trying to do and continue to do to try to make a measurable difference within Liberty City. Next slide. Work. We have a very disciplined approach of trying to engage leaders to work collaboratively. And one of the first things that we all work with and agree to, and as part of that also the community leads this conversation, is a clear result. So the result that we're aiming for Liberty City is a safe and healthy Liberty City. And this helps to ground the conversation in terms of reminding folks, whether we have some disagreements or arguments or some contentious conflict to negotiate, that we always come back to why we're all there together, which is around creating a safe and healthy Liberty City. In addition to that, another piece of work that grounds our discipline is having a clear set of indicators to let us know if we've made measurable progress on our result. So the committee and the community leaders have agreed to two sets of indicators, the first ones being total juvenile violent charges in Liberty City, and the other youth firearm injury rates in Liberty City. And you see some of the trend data from 2010 to 2014 on your slide. In addition, since originally when we started this work, there was a strong interest around focusing on health, the community decided to look at asthma rates as a proxy to get a sense of if we're making sure progress around the health of folks within Liberty City. And the two indicators they indicated were adult asthma ED rates as well as youth asthma ED rates within Liberty City. Now, work wasn't started by us. We came in and have been sort of the backbone organization, but it really was built on folks that had already been doing this work in the community, particularly the Miami Children's Initiative. After the Harlem Children's Zone in New York, this is a nonprofit that's been based in Liberty City for 7 years, and they have been building strong community relationships with many of the key partners. So I say that because in addition to their work, and they closely work with the Miami-Dade Health Department and our Jackson Health System, which is our main safety net hospital in South Florida, built these strong, trusting relationships. And so our role really was to integrate with what was already there to figure out how do we help to collaboratively get them to focus on these clear result of a safe and healthy Liberty City. Next slide. Very quickly, to give the context of Liberty City, because I think it's important in understanding the work that needs to go on for Liberty City. Liberty City, from 1933, was a city that grew out of segregation in Florida. Some people may know that for good parts of the South, segregation did not allow African Americans to live in certain parts of Miami, particularly places like Miami Beach. So you will typically hear that individuals like Muhammad Ali, although he trained in Miami Beach, could not live in Miami Beach. He had to go live in Liberty City and Overtown. Same with Sammy Davis Jr., Martin Luther King, and a host of other very notable African Americans. And so in 1933, because most of these individuals lived in Overtown, which is the original African American community in Miami, because of deteriorating housing and just lack of space, they created the Liberty City Housing Project in 1933, and that's how Liberty City was created. So to this day, if you see in the image there is actually a wall that still exists along 12th Avenue that signifies the divide between black and white communities in Miami. Next slide. So what we've been doing is built on this historical knowledge, and it has created, as you see here, much lower percentage of homeowners within Liberty City. Most of the people are in projects or subsidized housing, and also very high levels of poverty, as you can see compared to the blue bar, which is the average in Miami-Dade. Next slide. So some of the challenges, there still is a very vibrant community. We have strong relationships with the law enforcement, both the county and the city police departments. Community residents are very engaged with young people, and so this work has really been built on the passion of interest of trying to turn around Liberty City and how to create a safe and healthy community. Next slide. So like Liberty City, or for that matter, Baltimore, or any other city that you're trying to tackle an issue like violence and safety, you have to take for a population health level change. And the way we frame it from the work of my colleagues of Jolie Bain Pillsbury and others is the real work for communities to turn this around for population level change. Next slide. Think about it is based on this theory of change. This was created by my colleague Jolie Bain Pillsbury, based in Washington, D.C. and Virginia. And her premise and what we built this work on is that population level changes are most likely likely to occur if a group of leaders come together across sectors, implying that there is no one sector or one agency that can tackle some of these issues, and then focus their efforts on achieving a desired result. And the three core elements is that you have to establish an urgency, a sense of urgency and public accountability. There has to be a clear focus on what it is you're trying to achieve, and providing the skills for participants to work collaboratively together, to make decisions together, and to be able to negotiate through the challenging issues they may address. This is important because very often we focus on the sense of urgency, usually driven by the data that's available for that community, and sometimes have a clear sense of the result. But sometimes what we underestimate is although there is an interest and a commitment to come together to tackle an issue, most organizations and some leaders actually are not well equipped to collaboratively work across sectors, because you're dealing with folks that speak different languages, different the ways that they look at certain measures, different sets of interests, and so there needs to be a way to equipping and transferring this knowledge to leaders to say, how do we work across our sectors to make decisions together to effectively improve the health and well-being of our community. Next slide. This has taken the form of what we broadly call kind of leadership capacity building, but in essence, what we're doing is bringing folks together to have the conversations, to look at the result, where the root cause is, essentially a root cause analysis of what's driving those issues within that particular community, then getting even deeper into that to try to assess who are the key partners that need to be part of the conversation, and then moving to what works, and then thinking through what are we going to do as a community. So these meetings are held within the community. These are some of the folks that are there, and that's our State Attorney General and a few other folks that have been part of these conversations, because everyone tends to be grappling with this issue, at least for Liberty City, around violence from their own specific silo. And so this forum, this work that we're doing, gives folks a way to work across their sector, both to learn about what others are doing, but to figure out how to take aligned actions together. Next slide. This part has to talk about is around engagement. And the idea here is that you're really trying to engage a diverse group of stakeholders. First thing I would highlight is this work is really built around the community residents. I think all the time after doing this in a number of cities across the U.S., we get a number of well-meaning individuals that are very bright, that are very passionate about the issue, and the community voice may get lost in that process, or may not even be at the table. So this work is built primarily around the voice of the community. What are the issues they're grappling with around safety and violence? How are we going to address that? What are they most concerned about? And then with that, we begin to bring in an inclusive approach of bringing a number of stakeholders that all have either a public mandate to address those types of issues, say the health department, people that actually are service providers or emerging service providers like this faith-based community, and a few others that really have a vested interest around tackling this issue. And you want that you have and respective leadership as part of the conversations. The key to this is you want individuals that either have the capacity or have a proxy to be able to make key decisions for their organizations. And that could be medical professionals, that could be folks from criminal justice and law enforcement, youth and program providers, school systems, and government agencies. And as I mentioned, the meeting is usually held within the community in Liberty City, and really the carrot is to try to involve make sure everyone has a vested interest in that community. Next slide. What's the role of pediatricians? And I think there are a couple, because I kind of battled with this as a pediatrician myself and trying to think about, as I've walked this journey of trying to support building healthy communities, what were the different ways that a pediatrician can get involved? First click. One of the things I think we have to keep in mind is that we're looking at this through the lens of, with the community, that you're really looking at a life course approach. And the beauty for many of us in pediatrics is this is how we look at providing clinical care. It's just inherent and part of pediatric training. We know that there are different needs for children along different parts of the life course. And we're thinking of strategies around, for example, safety within Liberty City. It's not a one-shot deal. It's not a one program that fixes that. It really is multiple strategies along a life course where pediatricians, because we're naturally thinking this way, it brings a lot of insights and potential influence in helping to guide how to look at strategies along a life course approach. Next click. In addition, as pediatricians, we work and see children along the spectrum. So if you think about it, I mean, we see children upwards of 14 times by the time they're 4 years old. There's very few professions that have that kind of touch on the lives of children when you think about it in a regular context, because every child needs to have his physical each year. Obviously, when they're below 2, they're more frequent, but we need these children very often. So we have the opportunity to really engage and interact in a number of different ways. Next click. So specifically, you know, because we're in this unique opportunity to touch these lives, we're able to educate, identify, and potentially intervene or refer in just our one-on-one connections with families and with kids. In addition to that, we could argue that we are essentially kind of child health population experts, although may not some be trained in public health, but the mere fact that we see thousands and thousands of children, many of them from these communities, we see patterns of health and ill health just because of the volume of the work that we see, the number of work that we do for the children that we see. Part which I think often goes unnoticed, and this is a message that I share with many of my students, is that as providers, we bring a very credible voice for the community, because it's important for the community to hear about what the pediatricians are seeing and some of their thoughts on how to guide strategy development. For funders very often will want to know, well, what do the pediatricians in the community think? And they support over these efforts. And then so just in terms of having that conversation with other healthcare providers. And because we live both in a world of child health as well as clinical medicine, many of us are able to straddle and be connections to other healthcare providers. So the key for any pediatrician that's interested in this idea of how do I play a role to help improve population health, the question really is, which role or roles best fit my skills and capacity that I have to support the work of the community? It can be in multiple different ways. And I've seen pediatricians involved from the research aspect, where they've been heavily involved with helping to look at what do we see in terms of asthma readmission rates. In fact, one of my dear colleagues over at institution FIU has done some fantastic work to look at some of the asthma triggers and have gone out to homes to see the quality of housing, to see how that has impacted some of our asthma exacerbation rates that we're seeing in the emergency rooms. It could be from the context of helping to facilitate the conversations, which is a big role I play for some of the communities that we're working with. Or it can live just being a voice in the room to help share some of the insights that we bring from the patients that we care for. So I think as we think about this from the pediatric standpoint, is really trying to figure out, okay, based on what capacity I have, because obviously we're all busy with a number of different things, including clinical care, but which potential role fits my skill and what actually piques my interest around trying to be able to make a measurable impact and support the work within communities. I'll stop there, and I'll pass it back over to you, Courtney.
Thank you. That was a great presentation. And now we're going to move into the Q&A portion of the webinar. So just a reminder, if you have any questions for Dr. King or Dr. Agron, please feel free to chat those in the box. We'll move through those as they come in. So the first questions we received is for Dr. Agron and asking you to share some challenges you faced in starting Clinic in the Park.
Experts, and we see children more than any other professional in the first 5 years of life. Challenges were one, funding, and that's where the American Academy of Pediatrics catch grant process came into being. It's community access to child health. So once I gathered our partners together, and it really helped to get interested partners who are stakeholders in the community, who are leaders in the community, and represent the diverse sectors of the community providing child health issues, addressing child health issues. But we applied for a catch planning grant, and fortunately we're funded. Once we had the endorsement of the American Academy of Pediatrics, many members of the community saw this as a validated project and wanted to join. And I'll just add that as pediatricians, we can't address all the needs of our children and families. It's not a matter of treating the child with the ear infection. It's more a matter of, okay, we're living, what are your health needs, are you food secure? So many of our organizations want us to stock brochures and refer families to us. So this was sort of perceived as a way to say, okay, let's go out into the community, gather the partners that want, quote, into the pediatric offices and see if we can develop a collaboration. So it was the funding that gave us the credibility through the American Academy of Pediatrics that got us our start.
Thank you, Doug. We now have a question for Dr. King. Can you explain the role of public health professionals in forming these partnerships?
Absolutely. I think health professionals play a critical part in helping to, I guess, firm up and form the foundation for types of collaboratives. I mean, the Liberty City project, although I didn't talk much about it, was really built upon the work of Dr. Lillian Rivera, who is the director of the Miami-Dade Health Department here in Florida. And it was through her vision and her seeing this broader context of the population health needs of these communities that really helped to kind of set the foundation for this work. The strength of the public health practitioner is that, especially for folks like Dr. Rivera, is that they've been around and they have been involved in a number of population health initiatives, whether it's from asthma to HIV to Zika to whatever it might be. They have an enormous amount of credibility and connections. And so it really was Dr. Rivera and literally she and I going around from group to group talking to the police force and talking to county police force and talking to judges. I was just completely awestruck by the fact that every one of these sectors knew Dr. Rivera. And it tells you that public health has this very critical role of forming those relationships or helping to form those relationships because of the long history of the work that we've done within these communities. So I think that's one aspect of it. And then clearly the other piece of it is around the data. All the health data that we used to kind of look at indicators, all were driven by the work of the health department and the research staff with the health department. So I think from a governmental public health perspective, that's a key role. And then just from the academic standpoint, there's all the different research opportunities that have helped to shed more light around this. So I think public health from both sides can play a very important role in forming the foundation for doing this work for communities and establishing the credibility and the relationships to get things started.
Thank you, Dr. That's great, very insightful. Dr. Agron, we have a question for you about using Clinic in the Park. Someone says, using Clinic in the Park can also inspire kids to spend more time outdoors in nature and promote active lifestyles. Do you have a program to highlight the health benefits of green spaces?
Yes, when we were mostly at the Great Park, there is a large meadow there, and the city of Irvine brought their mobile recreation unit and so baseball clinics, soccer clinics, various activities, the kids. And what we tried to do with some of our partners is show them what they could do basically in their living rooms, in their home, in terms of simple physical activity like jumping on spots and so forth. We have a large group in our community who's promoting physical activity among low-income children who don't have backyards or don't have safe parks. So it's really showing kids how in your own home you can be active. Yes.
Dr. Agron, Tia's going to help me field some questions here.
Sure. We have a question, Dr. Agron, from a staff member at an AAP office, and they've created an agenda for children. They're currently providing direct service programs to the community, but are expanding the committees to engage more pediatrician members. Either of you, Dr. Agron or Dr. King, provide a tip to help them in recruitment.
Recruiters or pediatricians?
I'm thinking the recruitment of pediatricians.
Sure. Both of us, and Dr. King is doing this, would be glad to have a chair participate in any way we can to promote these kinds of partnerships?
I would, in terms of recruitment, twofold. We often joke that pediatricians suffer from BPS, busy people syndrome. And the truth is, for a lot of, let's say, clinical pediatricians, they just aren't even aware of what's going on in some of these types of initiatives. And so, case in point, when we were starting some of the work here in Liberty City, I had to intentionally go to the Department of Pediatrics, even though I know almost all the colleagues there, and do a full discussion with them about what we were doing in Liberty City, because they were all doing work that aligned with what we were doing in Liberty City, but were unaware because they were so focused in their particular niche or area that they were doing. So sometimes just going out there with a a short presentation or discussion to say, here's what we're doing, we'd love to engage you with this, and here's how we think you can help. Simply just putting that on people's radar makes a big difference. The other thing I think was helpful, and I think this is not just with pediatricians but with anyone else, is that if you're trying to engage folks, you have to think ahead of time, what are the interests of those individuals and how to frame this to align with their interests. Okay, we very often as human beings will approach something and say, hey, don't you want to be part of this? Isn't this great? And it's great from your perspective, but if you have a really busy pediatrician that's dealing with issues around meaningful use and their EHR, and they're having trouble with their scribe, this is not definitely up what they're looking for right now. So part of the work I think that falls on us, or the onus that falls on us, is that before we go out there to engage and recruit, let's say, pediatricians, whether it be academic or in private practice, is to think about first, what's in it for them? How do we frame this so that it aligns to what they're most interested in? And being able to do that is you have to ask them, what's their interest? And it's not usual for me, because I don't do as much clinical practice, but I do have colleagues now that are in full-time clinical practice, that I'll pick up the phone and I'll say to them, what is the most challenge you're facing right now in your clinical your pediatric clinical setting, and have this conversation. And the reason I'm doing that is to try to find out what are their interests, what are they most worried about. And as they're thinking and they're sharing with me, I'm thinking about, okay, well, maybe some of those interests I can align with what we're trying to do collaboratively in this community. And there's a way to kind of make that connection. And I often don't do that. We sort of think that because of the merit of the work that we're doing, and by putting out there, yes, everyone will want to jump on board. So we have to kind of step back and think about it not through our perspective, but what interests of the pediatricians that we're trying to engage.
Just jump in for a second. Our younger pediatricians have an advocacy rotation and community engagement rotation, and they've been assigned to come to the clinic in the park. So, just as our kids are our future, so are our young physicians. But I couldn't agree with you more, Dr. King, in terms of finding what the interests are of the pediatricians. For example, I've had our asthma doctor come in and do a health chat at one of the clinics on how you diagnose and screen for asthma. And, we found that they're not going to engage for many hours because of all the issues you mentioned associated with clinical practice, but we come on a Saturday for an hour and talk to some families. And very engaging, and it's energizing, and they enjoy it. But one size fits all.
For those great answers. So I think we have time for about one more question, and this one is for both of you as well. So one participant asks, living in a smaller, more rural community myself, do you have advice for starting up collaborative partnerships in areas where gaining tracking and support can be a challenge?
Not every.
Catherine, do you mind starting with
Sure.
that one? And then...
Sure. I think
Sure.
you find a couple. Oh, Dr. Even.
Oh, sorry, I was on mute and I didn't realize it. But go ahead.
That's okay. I just think, like, I spoke at a Lifesavers conference last spring, and engaging child transportation safety is a big issue, and particularly in rural areas. And it may be hooking up with Highway Patrol, it may be hooking up with the health department or a federally qualified health center, and finding just one or two people that share your agenda and pursuing, biting off a very, very small piece of it, and how you can advocate or participate or change something at a low level.
Mm-hmm. Yeah, I would echo that. I think what is helpful, even for rural communities, is if there has been some type of needs assessment, whether it's by the health department or whether it's done by an academic institution or some other agency, starting there to kind of get a sense of what qualitative data collection was occurring so that you can get focus group feedback. But I would give you a sense of what is it that the community is most concerned about. And I would start from there. So if that is available, that's great. And you can kind of see and say, oh, well, this community is really interested on the issues of smoking in our community. Then begin to, as Dr. Anger mentioned, start to have a series of conversations with folks to see how many other folks are interested in this particular area. And that begins to create a list of individuals that are interested, and then from there, just bring folks together to have a very informal conversation to see both the level of interest and whether there is a momentum to try to build from there, or if this might be something that folks aren't particularly interested in, but you can't garner a lot of support on. So I think it's a combination of seeing where folks are from the community, from some type of qualitative data assessment, if you have it. If not, then just starting to have conversations with people. And I think oftentimes we overlook talking to profit agencies that to have their finger on the pulse of what's happening for our residents in rural communities. So I'm thinking about things like groups like we have this service in South Florida called 211, where it's a way where people can dial in to say, oh, I need help with mental health services, or I need help paying for my primary care, or I need help for child care. That simple service, once we went and began to talk to them and said, what are most of the concerns and the calls you're getting about? You get enormous amount of information about what people are really grappling with, and gives you a starting point. So even if you don't have a needs assessment, you can talk to groups like that. Florida Legal Services has been another big one, but talking to them, and they'll tell you, we get tons of calls on this. They'll begin to give you a sense. And that's where I think you can start to get a sense of what are the needs for the community, and then being able to have a series of conversations, see if there's interest and momentum to build along those lines. A challenge we fall into is, I'll only speak for I have worked in, is when the pediatrician or the academic group has a particular area and they want to essentially community to engage in that work. So if I am a pulmonologist and I'm curious and interested in asthma, then what I'm interested in is the community helping me around improving asthma within Liberty City. But the disconnect is that might not be what the community needs right now. And that's some of the tension starts to occur around these collaborative partnerships where people will say, and they told us this in Liberty City, health is an issue. We're worried about asthma, but what we're really worried about is my child walking to school and not get shot. So there's a part of this where you as building these collaborative partnerships, we cannot leave out the voice of the interests of the community so that we can align what it is they need us to pay attention to with the broad population health issues we might be able to support them in.
Yeah, totally agree with that. I'll just add, sometimes, like in our community, for example, we had a measles epidemic, the Disneyland measles cases. So sometimes an event in the community, a school bus crash because the kids aren't wearing shoulder belts in their bus in a rural community, some issue can serve as a focal point for engaging and having conversations.
Absolutely.
Bradley, with the Practical Playbook, the two other places that we've seen communities come together are the faith-based communities, and second would be through the schools or the PTAs, because both of those are relatively well-established and connected.
Right.
Great suggestions. Great suggestions.
I'd like to thank you both for those great tips and examples, and unfortunately we're going to have to go ahead and wrap up at this time, but thank you all for joining us today. If you have any follow-up questions, please feel free to contact any of the staff whose contact information you see on your screen now. And I mentioned earlier, you'll be immediately directed to an evaluation at the conclusion of today's webinar, and we appreciate your feedback on that form. I'd like to thank the DuPont Foundation for sponsoring this, and our speakers, Dr. Agron and Dr. King, for their excellent insight in primary care and public health. The presentations will be available on the Practical Playbook website very soon, and you'll be receiving email links in the next few days. I encourage you to follow us through social media on the things listed on the page here. And we just hope that you will use this webinar as a resource and share it with others. And we appreciate your time today. Thank you all.
Thank you.